بسم الله الرحمن الرحيم وبه نستعين والصلاة والسلام على أشرف المرسلين سيد الخلق أجمعين سيدنا وحبيبنا ونبينا محمد. Greeting everyone. Welcome to our today's session about a continuation of sonographic anatomy series. Since we are still talking about breast anatomy on ultrasound, so we need to keep going through these slides to remind ourselves about breast composition. As you know, we have got a gland with a duct and lobule component together representing the glandular composition of the breast that embedded into a fibrofatty stroma, together forming the parenchyma. And any distortion or destruction in the parenchyma results in a breast pathology. At any moment, while scanning the breast, we need to remember or to put in our mind illustration of gross as well as microscopic anatomy of the breast. It will help us too much, as well as the breast physiology. And if you can see here, this is definitely glandular breast, the glandular component filling almost the whole breast with paucity of the pre-mammary and retro-mammary fat, the fibroglandular resting on the pectoralis. And this is a partially involuted breast with a band of fibroglandular parenchyma and thick fatty layer in the pre-mammary zone and a small layer of retro-mammary, and this is almost completely fatty breast. And why we need to know all this? Because you know that it will help us to understand from where the lesion arises. Okay, as you know, we have various pathology in the breast, and each pathology related to a different breast structures. This, when we are trying to imagine these structures and to relate these pathology, it will help us in interpretation and reporting. Let us mention again our goals or educational objectives of these series of sonographic anatomy lectures. We said we need to study the normal anatomic structures of the breast and their appearance on ultrasound, and to describe the normal anatomic variants and some abnormal appearances, understanding breast composition and background breast texture that could be seen on ultrasound, and to know some terminology used on breast ultrasound, as well as learning where breast cancer starts within the anatomy. Our reference mainly is Thomas Stephanos. Today, we are gonna talk about breast zonal anatomy. Here we have two panoramic ultrasound view, one for a glandular breast on the left, while the other for a fatty breast on the right. But the blue arrow representing the subcutaneous fat in both breasts, the fatty as well as glandular, and the green representing the fatty layer behind the mammary zone, what is called retro-mammary zone or retro-mammary fatty layer, and the yellow arrow represent the fibroglandular parenchyma, and here you can compare the fibroglandular parenchyma or the mammary zone between the two breasts. Here is the thick layer of fibroglandular, while this residual fibrotic parenchyma seen on the right side of the breast, sorry. Okay, so regarding the breast zonal anatomy, we have 3 zones. We have the pre-mammary and post-mammary zone, and the mammary zone is in between. This is a partially involuted breast with a moderate thick layer of mammary zone. So we can see abundant fatty layer in the pre-mammary zone and a good amount of retro-mammary zone, obviously visualized. More examples here. It is clear in this colored image for this ultrasound image, this thin layer of residual mammary zone seen in yellow here, in front of which the green is pre-mammary zone or subcutaneous fat, and this is good amount of retro-mammary zone. But let us check those on the left side. For this one, all this layer in front of this fibroglandular tissue, so all this is representing the pre-mammary zone. Okay, this is the pre-mammary zone, and this is the mammary zone, but unfortunately, the retro-mammary zone is not image or not representative in this image. Looking for this one. Here, you see, this all is the mammary zone. This is the fibroglandular parenchyma, but it is not, the contour is not straight, is wavy. Raising here, you see, elevated in this area, coming at the same level of pre-mammary zone. Here, this is a pre-mammary zone, and this pre-mammary zone, while this is still a mammary zone. And there is a small retro-mammary fat representing a retro-mammary zone. Okay, let us see the zonal anatomy in these illustrations one by one. Okay, as you know, the first layer, superficial, is known, it is the skin. Beyond the skin, immediately, we have the subcutaneous fat, which represent the pre-mammary zone. And it contains the Cooper ligaments. These are the Cooper ligaments. What these lines represent? So here, this line, this and this one represent what?
Superficial layer of the fascia, superficial layer of superficial fascia.
Okay, this is not a superficial. The superficial layer is just underneath to the skin, within the subcutaneous fat. But this here, outlining what is this zone? What is that zone? What is that zone? Okay, represent which one? This one, the subcutaneous or pre-mammary zone. So this, it will be containing the ducts and lobules. This, it will be the mammary zone. And the mammary zone outlined anteriorly by the anterior mammary fascia or pre-mammary fascia, and posteriorly by the retromammary fascia. So this is the mammary zone here in this illustration. So the thin layer, similar to subcutaneous fat, representing a thinner fatty layer, is retromammary zone or retromammary fatty layer. and underneath to this layer is the pectoralis muscle. So let us take this illustration and correlate it with an ultrasound image. Okay? This is ultrasound image, fortunately representing the anterior and posterior mammary fascia very obvious. Can you see the hyperechoic layer here, anterior to the mammary zone, and the posterior layer here, the retromammary fascia, and the pre-mammary fascia, or the anterior mammary and posterior mammary fascia. This is the mammary fascia representing these lines here, okay? And definitely this is the skin, and this is the subcutaneous fat or pre-mammary zone. And so here, this is a superficial fascia, you see? And these here are Cooper ligaments. And posterior to this, to the retromammary fascia and anterior to the pectoralis muscles, this thinner layer of fat is the retromammary zone. Okay, taking more examples, okay? Definitely here it is obvious. We can see the retromammary fatty layer, the mammary zone, and the pre-mammary zone were representative in this image. But going to this image, you see, ultrasound image, we have thick mammary zone. Okay. Excuse me, make sure your microphone is off. Okay, here we can see a thick layer of a mammary zone and pre-mammary zone. But this is the pectoralis muscle, except for this very thin, small area of retromammary fat representing the postmammary zone or retromammary zone. You see? And here we can see the breast resting over the pectoralis, except for this small retromammary zone. There is no representative of retromammary zone in this image, and the glandular is wavy. You see, elevated here, coming down and elevated here. So the mammary zone coming to the same level of the pre-mammary zone here. These are pre-mammary zone, and at this location, the mammary zone coming anterior to the same level of the pre-mammary zone. But this is well representative image for the three zones separately. You see, here we can see the three zones. Obviously, the pre-mammary, the mammary, and the post-mammary zone. But if we look for this image, we can see subcutaneous or pre-mammary zone, and this is the mammary, but we could not appreciate the retromammary as well as in this very thin layer of the pre-mammary and no post-mammary zone. The breast is fully occupied by fibroglandular parenchyma. As well as in this example, the breast is fully occupied by fibroglandular parenchyma with paucity of the retromammary fat and no with paucity of the pre-mammary fat or subcutaneous fat and no retromammary fat. Okay, here we can see pre-mammary zone well seen, but no retromammary zone, the mammary zone resting into the pectoralis. Do you have question?
قال احسن بالله.
Sorry, there is background noise.
يا دكتور رباب ممكن تعملي الميوت اول من عندك.
From where?
بتلقيها قاعدة تحت.
Mute all.
لو دخلت البارتيسيبانتس محل البارتيسيبانتس من تحت بتلقي ميوت اول، بس اعملي لها ميوت اول.
اوكي. 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 Okay. Here, this we can say, we said that there is pre and retromammary zone, good amount of retromammary because it is partially involuted. And this is because it is almost all involuted. The mammary zone is very thin, and the whole breast representing pre-mammary fat and large layer of retromammary fat or retro-mammary zone. Okay. We have to go through this image of, do you remember it? Scale of echogenicity. Do you remember the scale of echogenicity? Because we are talking about structures, okay? And to remember each is the echogenicity of each structure, let us revise this scale again. We said when we adjust our ultrasound machines, the fat, the epithelium, and the loose stromal tissue are seen as medium gray. But you know that there are variations in the breast. Not all breast you can see epithelium, and not all breast you can see stromal tissue. But definitely, if you review the all previous images, almost all, we could appreciate fat, at least a small or thin layer of subcutaneous fat supposed to be detected or visualized in our ultrasound images. So because the fat is available in all breasts, that is why it's chosen to be the frame of reference, okay? And it is a medium gray. So any structures or lesions with echogenicity lower than the fat, it will be hypoechoic. And those similar to fat, it will be isoechoic. And those higher than the fat, it will be hyperechoic. Okay, we have mentioned that the loose stromal tissue seen in periductal stroma and intralobular stroma. It is seen as gray. You see, it's seen as gray here. This is periductal stroma, and you can see here might be this is intralobular stroma. Okay, while the compact stroma, okay, representing the Cooper ligaments, anterior mammary fascia, posterior mammary fascia, superficial layer of fascia, and the interlobular fascia are bright, hyperechoic, not echogenic. Don't say echogenic. Echogenic is wrong. We have to say hyperechogenic or hyperechoic. Okay, so the bright echoes we have seen here in fibroglandular represent it is interlobular stroma. This is representing the interlobular stroma. This is the superficial fascia layer, bright Cooper ligaments, bright oral compact, anterior mammary, posterior mammary, fascia compact, all are bright, and the brightness here is due to interlobular fascia. Here, this is This is a duct. And these are lobule. Within the lobule, as we have mentioned before, there are acini embedded into intralobular stroma. The stroma inside the lobule, as seen here, representing as light brown. This is intralobular stroma. The intralobular stroma, it is grayish, while the dark brown outside surrounding the lobule, here and here and here, all the lobule surrounding by the extralobular stroma or interlobular stroma. This is the compact stroma, the brightish one. It appears as hyperechoic and representing the whitish, okay, or hyperechogenicity here within the mammary zone, and these smaller grayish representing periductal and intralobular stroma. Is it clear? Okay. Then let us talk about different types of fascia. Okay. Talking a little bit about the stromal component. Last time we discussed the glandular component. Today, let us go through a little bit stromal component, going through the zonal anatomy. Okay. As you know, the breast is a modified epicrine sweat gland that developed and enveloped between two layers of the superficial fascia. You see, this is the breast. Here we have the superficial layer of the superficial fascia and the deep layer of the superficial fascia. Okay? The superficial layer is an incomplete layer, interrupted here at the nipple areolar complex. See? Covering the breast underneath the skin, as you have seen it here. Usually we have seen it on ultrasound. As we said, part of the compact stroma, that is why it is hyperechogenic or hyperechoic. We have seen it as a line or a band, thin band of hyperechoic just underneath to the skin. Okay, but you could not see it at the level of the nipple areolar complex. It is missing in this region. And the deepest one, usually because the structures are crowded posteriorly, and we could not usually appreciate the posterior layer of the superficial or the deep layer of the superficial fascia. We have also, as we mentioned before, anterior mammary fascia. The anterior mammary fascia is also interrupted here. It's also interrupted at the nipple areolar complex, okay? And just covering the mammary zone. You see? It's covering the mammary zone. So the pre-mammary zone is between the anterior mammary fascia and the skin, including the superficial mammary fascia. From this is the anterior mammary fascia. This is the anterior mammary fascia, and this is the pre-mammary zone or subcutaneous fat, including within which the superficial layer of fascia traversing the pre-mammary zone. And here posteriorly we can see the posterior mammary fascia or the retro-mammary fascia. Okay, completing the encasement along with the anterior mammary fascia are encasing the mammary zone. The mammary zone. Okay. This is the most representative ultrasound image for both the anterior and the retromammary fascia. You can see it here. This is the retromammary fascia. This is the anterior mammary fascia or pre-mammary fascia. And this is the superficial layer of the superficial fascia. And we can see part here of the deep layer of superficial fascia. You see, we can see it here. Okay. Going further, we discuss the superficial fascia and the anterior and retromammary fascia. What about the Cooper ligaments? Okay, as you know, the Cooper ligaments are the infrastructures of the breast, are supportive fibrous band traversing the breast and holding the breast, going from the mammary zone toward the skin, and from the mammary zone back to the pectoralis fascia. And it is generally, you see, you can see it here. These are the Cooper ligaments, radially oriented, and it is best seen in the subcutaneous layer. You see, we can see it here. This is the, we will see it again because here it's only, okay, let me show it to you. Yes, yes. You see, these are the Cooper ligament. These are the Cooper ligament. You see, these are the anterior one, and here this is the posterior one. Okay, and here because annotated with color. So these, the pink one, are the Cooper ligaments, and this is here the superficial layer of superficial fascia and the deep layer of superficial fascia. The anterior one attached to the anterior layer of superficial fascia, and those attached to the posterior layer. And this is the residual fibrous parenchyma or fibroglandular parenchyma. Okay? Okay. How does it form the Cooper ligament, or from which the Cooper ligament start? If you can see here, we mentioned before in blue, anterior to the mammary zone, we have which fascia? The anterior mammary fascia. So this blue is the anterior mammary fascia. This anterior mammary fascia elevated going here and coming back, forming a Cooper ligament. Again, going and coming, forming the Cooper ligament. So the Cooper ligaments are two layers, folded layers of anterior mammary fascia extending from the mammary zone to the subcutaneous part of the breast to attach to the superficial mammary, superficial fascia. Here you can see the superficial fascia, and here this is anterior mammary fascia. Okay, going, coming, here coming, going and coming, forming the pectoralis, and the pectoralis attached to this layer. And here in green, this is the posterior mammary or retromammary fascia. Okay. Okay. So here you can see the directions of the Cooper ligaments. The anterior mammary going and coming back like this. That is why it is not just a single layer or thin layer. If you look here, you can see it is like a peak. Okay? It is the peak, a Cooper peak. Can you see it here? You see, you can see the gland going and coming. Okay. What is the importance of the Cooper ligaments? As we discussed before, the Cooper ligaments have variable appearance. Here you can see it as very thin, linear structure, hyperechoic structures. Here, a little bit thicker, and you can see the base of which as a peak, and so forth. You see? What does it represent, this image? Could you imagine what is going on in these two images and what is the difference between the two? Any volunteer? Any volunteer? Okay. If you look here, you can see more shadowing. You can see more shadowing. And in the other image, the shadowing a bit resolving, less shadowing than this one. And at least here we can see obliquely oriented Cooper ligament. So this is a shadowing, okay, from a Cooper, acoustic shadowing from Cooper ligaments. See, as we mentioned, the Cooper ligaments are compact connective tissue ligaments, compact stroma. So it results in refraction of the sound beam. That is why giving acoustic shadowing with more compression, make it more horizontal. You see, this shadowing, it will regress or resolve. And this is really significant and important while scanning, because one of the pitfalls of ultrasound. If you see these images here, this is the transverse and this is a sagittal view, okay? Look, the more heterogeneity of the breast, the more shadowing from the Cooper ligaments, and seen more in the sagittal view than in the transverse view. Here you can see this is a shadowing behind the Cooper's ligament. Here in the sagittal view, and the breast is more horizontal, giving a little bit more shadowing. What is the difference between these two images? Can you call all of these shadowing from a Cooper ligaments, or you can suggest the lesions? Do you suggest any abnormality, or just you can label it as, you are going to label as just shadowing from a Cooper ligaments? You are unmute if you want to share. Any suggestion? Any difference between these two images? Okay. There are shadowing here, and we can see some angulation here. So expected this to be from Cooper ligament, but we need to clarify. We need to make sure that this is due to Cooper ligament. But when I look here, this shadowing, there is subtle distortion. There is a subtle distortion associated with this shadowing. Okay, so in this case, invasive ductal carcinoma present, while in the others proven to be just a shadowing from Cooper ligaments. And this is one of the pitfalls of ultrasound, and we have to make sure if the shadowing is just shadowing from a Cooper ligament or due to underlying non-mass ultrasound lesions. Okay, again, Cooper ligaments, suspensory ligaments are really important while scanning. We have to know more and more about these ligaments, okay? As we mentioned before, it starts as a peak or a ridge, we said. It starts as a peak or a ridge, 2 layers of the anterior mammary fascia. So here giving what? It has a base. This is the apex, and here it is the base. It has a base. And as we mentioned, it is not attached to the skin. It attaches to the superficial layer of the superficial fascia. Okay? And it often contains ducts and terminal ducts, lobular units. And not only that, they have mentioned that the terminal duct lobular units, you see, at the Cooper base here, are larger and more than in the parenchyma in between. If you look here, there are more numerous Cooper ligaments, more numerous TDLUs than here in between the Cooper ligaments. And the Stephanos have a theory for that. He suggests that there is better blood supply at the Cooper base, and he also suggests that this area exposed to higher estrogen level than the area in between. Okay? And as you know, as we mentioned before, that the Cooper ligaments, the TDLUs are more in the anterior half of the breast than the posterior half. You can see it here. Are more numerous anteriorly, but look for the posterior, are much less number of TDLUs. If you look here, you can see this is the Cooper ligament, and you can see here the gland going into the base of which. Can you see it on MRI here? You see there is enhancement. This is part of the breast gland seen at the Cooper base. Okay. What is the clinical significance of that? As Stephanos described, he mentioned that the anterior mammary fascia, okay, acts as a fence that resists the spread of cancer or contain the cancer within the mammary zone and try to prevent it from spreading beyond the mammary zone. But the same mammary fascia here, elevated, going here and coming. So he considered this the base of the Cooper ligament represent the gate, okay, at this fence. So cancer can spread or can extend through this weakest portion of the anterior mammary fascia. And that is why, okay, when it extends through this beak, giving the angular margin. And here, this is can explain the angular margin of the, one of the explanation of the angular margins of the breast cancers. And here we can see two breast cancer, two lesions representing breast cancer with angular margins at the Cooper base. You see, you can see it here. That is the largest one, and here the smaller one. Can you see it on ultrasound? This is one Cooper ligament, and this is another Cooper ligament. And at the Cooper base, you can see here, these are the two invasive carcinoma. See? And I did search looking for other lesions than breast cancer that can giving angular margin or can spreading through the Cooper ligament. And I found, you see, a granulomatous mastitis also limited by the anterior mammary fascia and is spreading here through the Cooper ligaments, you see, simulating a breast cancer. Here you can see the Cooper base giving the, this is a normal one, but if if a lesion is spreading through which, definitely it will give angular margin. Look, this is a cyst. Here more rounded, but when it goes through this Cooper base here, you see, there is subtle angular margin. This is definitely a simple cyst, a benign. And even here, this is a fibroadenoma. Pathology proven fibroadenoma also have subtle peak here at the Cooper base. So not only breast cancer at the Cooper peak can give this appearance, but definitely there are other features that can characterize the breast cancer. However, in the case of this granulomatous mastitis, definitely is really difficult apart from the clinical and probably might need to go for biopsy and pathological diagnoses. Okay. As you know, usually we can see, we have seen the breast pathology within the mammary zone. Okay, this is the where the gland is present, the duct and terminal duct lobular unit, and almost all pathology arises from these, either from the terminal duct lobular unit or from the ducts which are present within the mammary zone. So we expect here, this is all, these are examples of DCIS, all are present within the mammary zones. This is a cyst within a mammary zones, involuting fibroadenoma, granulomatous mastitis, all within the mammary zones. And here we can see, you see, sometimes the lesions within the mammary zones bulging anteriorly into the pre-mammary zones. Okay, but if we look for these, and here, sorry, some of these, here, this is just attached to the mammary zone, but almost surrounding by fat and similar these three lesions. But if you look for these cancers, these are all invasive cancer. Here, what we can see, completely surrounding by fat throughout. And not only cancer, this is hemangioma, this fibroadenomas, and this is adenosis, benign breast lesions completely surrounding by fat. Okay. If virtually all pathologies arise from the terminal duct lobular unit and or ducts, and if all ducts and terminal duct lobular units lie within the mammary zone, how do we get benign or malignant breast lesion that completely surrounded by fat? Do you have any suggestion for that? Any suggestion?
It is difficult. It's difficult by margin to define, to characterize. Yes. It is difficult. Difficult because both benign give angular margin. Benign and
I'm not talking about the angular margin now. I'm talking about the surrounding fat. Because we could imagine to have a disease or to have a benign or malignant lesion within a mammary zone. Okay, we know that within the mammary zone we have terminal duct lobular unit and we have ducts from where the pathology arises. Almost most of the pathology arises from the gland, from the epithelium. Yes, especially breast cancer. Yes. So if I have seen cancer or benign lesion in completely fatty breast, from where this lesion arises. From where does it arise? Do you know? Okay, let us continue. Stavros explain the reason for that. Okay, look here. We have a glandular breast and there are terminal duct lobular unit. Can you see any terminal duct lobular unit here? This is the parenchyma is almost uniformly echogenic, yani more or less fibrotic, involuted, with very limited ducts and lobular visualization. And here it becomes almost fatty. Okay, and this illustration demonstrates a segmental ducts and the terminal duct lobular unit anterior more than posterior and larger than posterior, and extralobular terminal duct longer anterior than posterior, as in this illustration also here. In this fatty breast, still we can see illustration demonstrating terminal duct lobular unit and ducts. Where could it be? These, could you imagine if you could apply this illustration here? Could you imagine where could be available these terminal duct lobular unit and these ducts within this fatty breast, where we could find it?
Posteriorly.
Okay, let us continue. Okay. Again, here in this image, we have more isochoic lobule seen anteriorly, okay, in a glandular breast. And if you look here, start to get atrophy, okay, with aging and with multiple lactations and pregnancies, the gland start to be involuted. And what will happen here? You see what you can see here, the Cooper ligaments, there is some indentation, okay? There is indentation between the Cooper peaks. And this indentation become deepen and deepen and deepen, okay? Until it become almost fatty. When it start to get deepen, virtually all remaining TDLUs and ducts are left entrapped within the Cooper ligament. So when the breast completely fatty, still there are a lot of residual Cooper ligaments. So within these Cooper ligaments, we have entrapped TDLUs and ducts. And from these entrapped TDLUs and ducts, lesions can arise, and then it can be visualized as completely surrounded by fat. Is it clear? Is it clear?
Yes.
Okay. Thank you. Okay, so Cooper ligaments, as we mentioned, attached to the superficial fascia, not the Cooper, not to the skin. Okay, and there is and when we look here to the superficial fascia, in this example, the superficial fascia is straight, while in this, there is scalloping or there is indentation due to pulling of the fascia by the Cooper ligament. So the fascia either can be seen as straight or can be seen as indenting or scalloped. Okay, can you visualize the superficial layer of superficial fascia in these examples here? You can tell me, yes, here it is very obvious in this fatty breast, it is here. And even this glandular breast, I can see it here. Very clear away from the skin. But looking for the upper row, these examples, I can see part of which here. Here, I could not, maybe here, you see, is hardly visualized, hardly perceived. You see, can you see here? Part of which? Sorry. Here it is there, okay? So, this is the superficial fascia. What is the difference? Why in some individual we could easy seen or visualize the superficial fascia while the others difficult to be perceived? In a slim woman, okay, a skinny woman, there is no fat, it's difficult to be visualized. You can barely see it. It will be just very close to the skin. While in a fatty woman, you see, there will be a good amount of fat between the fascia and the skin, so we could well visualize it. Again, here we have different examples. You see, here, this is a glandular breast, but it is almost close, while this is again glandular breast, but we can visualize it separately. Here, this is a fat, these two examples of fatty breast. You see, this is very close to the skin, while this, there is a good amount of fat separating the fascia from the skin. So it is not related to the involuted breast or glandular breast, but it is related to the body habitus of the female. And even here, this is partial, partial involuted breast or not very thick layer of fibroglandular parenchyma, okay? And this is very close to the skin, while this is a little bit away from the skin. So it is related if the lady is skinny or if the lady is fatty, you see? So to have a space between the fascia and the skin to be perceived. طيب, why superficial fascia is important? Why it is important? Okay. It is a lymphatic rich area, okay? Along the superficial surface of the superficial fascia, it is the rich lymphatic area freeway to the retroareolar or the sabis plexus. So if there is a large lesions grows up to this superficial fascia, or if there is a small cancer arises within that area, okay, this is most likely, okay, to invade the lymphatic and spread to the axillary lymph node. If any lymph node, non-specific or undeterminate lymph node present in the ipsilateral axilla, we have to biopsy that node, because the lesion in a predictive locations of metastasis, and most likely the lymph node, it will be metastatic. So we have to be aggressive with lymph node and to put a needle and biopsy that lymph node. We'll go through some of the examples. This is my patients. You see, look for the primary lesion is a unifocal sub-centimeter lesions, but where in a predictive locations. Infiltrating here, arising and infiltrating the superficial layer of the superficial fascia. Can you see it here in the zoom view? Invading, okay? And this is the ipsilateral lymph node. Here, this is the lymph node, and this is the mass infiltrating the lymph node. Can you see it here? Irregular mass infiltrating the lymph node from these sub-centimeter lesions. And it was proven to be a metastatic lymph node. Again, this is my patients. This is a large lesions within the mammary zone, but extending, you see, and invading the superficial fascia. And this is non-specific lymph node with 0.5 centimeter cortical thickness, you see, proven to be metastatic. On imaging, it is a borderline, but pathology proven metastatic lymph node. Why? Because if you look for the lesion extending, you see, and even here, there is suspicions of lymphatic invasions of the focal lymphatic invasion of the overlying skin. This is my patient also, and this is in the upper outer quadrant. We could appreciate here the invasion of the subcutaneous lymphatic vessels by the tumor, okay? And look here, the skin edema and the perilesion edema. And the same breast, look for the subareolar region, how it is infiltrated and edematous. You see, and as you know, any lesions, you see, or a lesion for any given size in a subareolar region is also considered a predictive locations. Because of lymphatic rich regions, any lesion in subareolar, in the retroareolar, it will go directly to the axillary lymph node, and most of the time it will be metastatic adenopathy, associated with metastatic adenopathy. But as you know, in our patients, you see, even from the retroareolar, the lymphangitic spread going into the inner lower quadrant and across the valley of the breast to the contralateral breast. This is one of our patients of lymphangitic spread to contralateral breast. Okay, this is also my patients. Okay, can you see the lesion here? And look for the edema extending, you see, here in this although the lesion, it doesn't look, it is a unifocal, okay? And the amount of edema is much larger than the lesion itself, including the lateral aspect of the breast and extending to the nipple areolar complex. And here, that is a lesion on ultrasound. You can see it. It is a relatively larger lesions extending from the mammary zone into the superficial layer of superficial fascia associated with some skin thickening. And here you can see this is subcutaneous lymphatic vessels prominent. Also, you can see it here. As we mentioned before, the area between the superficial layer of superficial fascia and the skin is a lymphatic rich area. And if you look for this, it is 0.4 cortical thickness, diffuse cortical thickness, but it was metastatic lymph node. If I ask you for this case, if you have this lesion here, and you have this lymph node on ultrasound image. Do you recommend biopsy for this lymph node, or just you will report it as a borderline or non-specific lymph node and you will leave it? Or you recommend follow-up or something regarding the adenopathy? Do you recommend biopsy for this lymph node or not, and why?
We recommend further evaluation by biopsy because the lesion
Yeah.
infiltrating the anterior mammary fascia.
Excellent, well done. It is a superficial lesions. It is invading the superficial fascia and abutting the skin. So this is a predictive location of metastasis. Even if it is smaller than this, it is almost 1 centimeter lesion. This is magnified view. Okay, but even if it is sub-centimeter, you have seen my case previously. This is not my case, but you have seen, I don't remember it online, if it is mine or not. But the first one, that sub-centimeter, look for sub-centimeter, small unifocal sub-centimeter lesion with a big mass, metastatic nodule, okay, infiltrating the lymph nodes. So these are predictive locations of metastasis. For these, for associated breast cancer in these locations and non-specific lymph nodes, we have to be aggressive and we have to proceed for biopsy, as you mentioned. Thank you, Zuhair. Okay. Okay, we discussed the fascia and the Huber ligaments. Let us go for the zonal anatomy. Starting from superficial, going to the deep. The first one, it will be the pre-mammary zone. As we have mentioned before, you see, this is the pre-mammary zone. And as we said, it is variable in thickness. Okay. As we mentioned before, we usually see breast lesion within the parenchyma. But does the lesion always confine to the parenchyma or to the mammary zone?
No.
Can we see a lesion outside the mammary zone?
Yes, if there is a terminal duct lobular unit being between two layer of superficial of the fat, if left part of terminal duct lobular unit left between the fat, we can see the lesion in the we can see the lesion between the fat.
Okay, if the breast is involuted, but I'm asking,
yes,
you see, if you have a good mammary zone, can you see a lesion in the pre-mammary or retro-mammary zone?
In non-involuted breast?
Non-involuted breast, yani like this one, okay? Like this breast. Can you see or can you detect any lesion in the subcutaneous fat or in the retromammary zone? Or only we expect to see lesions within the mammary zone if we have a non-involuted glandular breast?
just to the mammary zone. You cannot see it outside because the breast is enclosed unless interrupted of the superficial fascia, unless there is interruption of superficial fascia. No interruption of superficial fascia, the lesion enclosed in the mammary zone. Just
okay. Let me ask you in different questions. Okay. Do you expect to find any lesion arise from other structures than terminal duct lobular unit or duct in the breast? Yani if you have a patient, okay, presented with a palpable abnormality, what are the differential diagnoses? Could you expect to find something not arise from a duct or not arise from terminal duct lobular unit, or it has to be arise from this?
yes, you have other lesion from the
Yes.
arising from the structures.
Yes. What? Like what?
The
You are right.
the fibrous tissue of the gland of the mammary of the mammary fascia, like fibrous.
Stroma.
Yes.
Stroma. Yes. You
Stroma.
mean the stroma? Yes.
Stroma.
You are right. There are lesions arising from stroma. Okay. Okay.
Yes.
What else?
From blood vessels also.
Excellent. There are other structures. There are vascular lesions. Okay.
Lymph node.
Lymphatics.
Okay.
Lymphatics. Yes. Yes. Excellent. What else?
From the fat.
From
the fat, maybe.
From the fat. Excellent. Yes. So, starting by the pre-mammary zone, what do you expect the structures within this zone? And according to these structures, we expect the differential diagnosis of the lesions. What is the subcutaneous fat? Represent what? It is part of which? Of what? The subcutaneous part, we discussed it before, so here we discussed the subcutaneous fat.
Yes.
We have mentioned that subcutaneous fat is part of the third layer of the skin. It is the third layer. It is the third layer of the skin.
Yes.
You remember this illustration before? Do you remember it?
Yes.
Okay. We have mentioned that the skin composed of 3 layers. The epidermis and dermis, we could not differentiate it on imaging. These 3 lines, 2 echogenic and the grayish layer in between, represent both epidermis and dermis. And the fatty layer beneath the dermis is the epidermis, the hypodermis, I mean. Is that the hypodermis? Is the hypodermis or subcutaneous fat? And here, regarding zonal anatomy, this subcutaneous fat represent the pre-mammary zone. So the pre-mammary zone is part of the skin. Is a part of the skin. Okay, it is predominantly fatty layer, contain superficial layer of superficial fascia and the puber ligaments, and it contain vessels, contain lymphatics, contain the skin. You see, and it is just anterior to the anterior mammary fascia and posterior to the skin. So most or usually the lesion arises within this area, representing what? A dermal lesions, a dermal like any skin lesions arises in the other part of the body. Okay, so as you know, it is rich in lymphatic, as we have mentioned earlier. Okay, rich in lymphatic, and it contains Cooper ligaments, contain blood vessels, and contain nerves, contain and also we are going to discuss later, it might contain something I'm not going to tell you now because I'll ask you about it. Okay, so considering the differential diagnosis, most of the lesions within the pre-mammary zone are non-glandular lesions. A non-glandular lesion mostly are dermal lesions. And most of the dermal lesions are a dermal cyst, either epidermal inclusion cyst or sebaceous cyst. By imaging, difficult to differentiate between the two. Here we have some example of epidermal inclusion, and here we have example of sebaceous, but if you look for this, more or less similar, okay? And so usually we just raise the differential diagnosis for clinical correlations. Okay, so also contain fat. So non-glandular lesions, fat-containing lesions, lipoma, angiolipoma, fibrolipoma, fat necrosis. So these are example of fat necrosis here. You see, this is the, what do you suggest? The transducer of this and this. You have seen it before. This is 22 and this is 15. It's okay. Look for this. You see ugly, suspicious lesion. It was a fat necrosis. As you know, fat necrosis, and even this one, is a mimicker of breast cancer. And in this case, this is post-traumatic changes. Okay, as you mentioned, okay, blood vessels, vascular lesion. Vascular lesions can be hemangiomas. We have variable appearance of hemangiomas, though are not common, are uncommon lesion in the breast, okay? And the malignant, the angiosarcoma is more common than hemangioma, but there are variations from benign appearing to suspicious appearing lesions. Can be hypo, can be iso, can be hyper. Okay? And we have also thrombophlebitis. Can be seen like this or can be seen as beaded appearance, what is called Mondor's disease. And Mondor disease can be related to trauma, can be idiopathic, but we have to exclude underlying cancer because it might be associated with underlying cancer. Okay, and in this case here, it's only just a dilated veins. This is examples of angiosarcoma, breast angiosarcoma, you see. Regarding the neurogenic lesions, most of the lesions are either schwannoma or neurofibroma, and it's difficult to be differentiated by ultrasound. Here example of schwannoma and here example of neurofibroma. But the patient of type 1 neurofibromatosis, you see, they have 5-fold increased risk of breast cancer in premenopausal women. And if the patient have neurofibromatosis, you see, and we have a lesions, we have to exclude breast cancer. And in this case, this mass seen here, it was invasive cancer. And it is important, the clinical history, biopsy, and all these is important in case of neurofibromatosis. Lymph nodes, you see, it is one of the commonest lesions. It's seen in the superficial breast, sorry, okay? This is a normal lymph node, okay? Here, this is 22 transducer, 22 megahertz transducer, but definitely this is our abnormal lymph nodes. See, in a case of lymphoma, this is a lymphoma. Though lymphoma in the breast is very rare, and when it's seen, it's mostly secondary or disseminated disease, not a primary lymphoma. Differential diagnosis in pre-mammary zone also can include radiation-induced sarcoma, as in this case, rare lesions, but we have to put it in our differential diagnosis, especially if the patients post-radiation treatment, treated patient, I mean. Okay. Here we can see 3 invasive cancer in the pre-mammary zone. How you are going to evaluate this lesion, or what do you suggest? Why these lesions are seen in the pre-mammary zone? In this case, here, the epicenter of the lesion is obviously seen within the mammary zone and seen here extended in the pre-mammary zone and to infiltrate the skin. But here in these 2 examples, it is primarily the lesions seen in the pre-mammary zones. How you are going to explain why these invasive cancer are seen in the pre-mammary zone?
There is invasion of the superficial fascia. There is destruction or invasion of superficial fascia.
This one here, this is the invasion of the superficial fascia. This one here, there is invasion superficial fascia as well as the skin. But this lesion is arising, it seems, the epicenter of the lesion within the hypodermis and infiltrating, overlying the skin. The bulk of the lesion, it doesn't seem to be a large lesions, as in the first example, coming from the mammary zone into the pre-mammary zone. It seems to be a rise within the pre-mammary zone. How you are going to explain this?
Sorry, what do you mean explanation of the lesion or the sequence of the lesion? What do you mean?
No, why we have a superficial invasive cancer? How you can explain, and if you can find, if while you are scanning and you detect a suspicious mass in the subcutaneous or in this pre-mammary zone, what is your differential diagnosis for that?
metastasis.
Who said metastasis?
أنا Islam.
You are welcome, Islam. Yes, metastasis is one of the differential diagnoses, but this is a primary lesion.
Maybe ectopic tissue.
Huh?
Maybe ectopic tissue seen in the pre-mammary zone.
Excellent. Islam?
أيوة Islam.
Excellent, Islam. 100% correct. You are right. This is ectopic TDLUs. Okay? As we mentioned, all the previous differential diagnoses, it was non-glandular lesions. But it is written here, glandular lesions and anterior TDLU lesion. Okay? Let us see more example. This is papilloma. Where? Look, in the pre-mammary zone, abutting the skin. This is involuting fibroadenoma. Where? Primarily here, okay? In the pre-mammary zone. Mucinous carcinoma. Again, you see, even invaginating into the skin, all in the pre-mammary zone. It is not very common, but we have to be aware about this. The question again, if virtually all breast pathologies arise from TDLUs and ducts, and all ducts and TDLUs lie within the mammary zone, how do we get benign or malignant lesion that completely surrounded by subcutaneous fat, or i.e. in the pre-mammary zone or in the subcutaneous fatty layer? As you mentioned, Islam, you see this segmental duct and these TDLUs, you see, here there is a Cooper ligament and one TDLUs here. This is entrapped within the Cooper ligaments, and we have ectopic TDLUs. As we mentioned before, we have multiple TDLUs at the base of the Cooper ligament, but we can have an ectopic TDLU within the Cooper ligament far away from its base, as we have seen in the previous illustration. And this can be seen only in 1 to 2%. There's almost 99 of TDLUs and ducts are within the mammary zone, but 1 to 2% can be seen ectopic in the pre-mammary zone, and extremely rare can be even seen within the Cooper ligament in the retro-mammary zone. Okay? So, that is why Stavros explained why prophylactic subcutaneous mastectomy can reduce the chance of cancer in 90 to 95% only, not 100%, because there are ectopic TDLUs and cancer can still arise from these residual ectopic TDLUs. Okay? So the differential diagnosis within the pre-mammary zone can be explained or can include fibroadenoma, peripheral papilloma, and even cancer within subcutaneous layer. Okay? Here we have different examples. Can you see all these examples? You see, all are just superficial. You see, so superficial. This is a papilloma. This is fibroadenoma. This is sclerosing adenosis. And this is ductal carcinoma in situ. Arises from anterior or ectopic TDLU. Okay, so breast lesions are not always confined to the parenchyma. There are 1 to 2% ectopic TDLUs that lies within the Cooper ligament and surrounded by subcutaneous breast fat can arise. So cancer can arise from these ectopic lobule within the subcutaneous fat. Okay, we mentioned this. Okay, this is papilloma, and this is fibroadenoma. Can you tell me, is it arises, what do you suggest? Is it arise from a usual TDLUs or from an ectopic TDLUs? And why? Huh? Still, we have a lot to discuss. If you don't know, say we don't know, let us proceed. I brought this example to clarify things. As you know, and as we mentioned before, you see, the mammary zone is coning, okay, to enter into nipple areolar complex. So close to the nipple, okay, still we have mammary zone up to the nipple areolar complex. We have duct entering into the nipple. So that is why when we see a lesions obliquely oriented near to the nipple, because those are coning like that, going in that direction, we consider it as a parallel. And for that reason, for the same reason, here, this is papilloma, very close to the nipple. It arises from the ductal system of the mammary zone, because the mammary zone reaching the nipple. And in this example here, it is obvious she has a thick layer of fibroglandular parenchyma, okay, with paucity of the subcutaneous fat. Look for the subcutaneous fat, very thin layer of subcutaneous fat. So the parenchyma itself abutting the skin, coming and filling that space. That is why it is seen as a superficial lesion. But if you look here, it is almost surrounded by by gland or by parenchyma. So these two examples are not anterior TDLUs, okay? Okay, how do we differentiate glandular from non-glandular superficial lesions, breast lesion, or differentiate these superficial lesions might be arises from anterior TDLU, or this is non-glandular lesion arises in the subcutaneous layer. Okay. Definitely here, this example is very clear that this is a dermal lesion, because this is it is contained within the dermis. So no doubt for this. Here, I have a lesion, part of which within the skin and part within the hypodermis. Part within the dermis, part within the hypodermis. But it is more or less typical. It demonstrates the close sign. It has hyperechoic thin wall posteriorly, posterior enhancement, and more of the half of which within the skin, and demonstrate the close signs. So all these are supportive to be a dermal origin, same applied to smaller lesions. So this is most these characters going with a dermal origin or a dermal cyst. But I have here 2 examples. These are definitely within hypodermis because the angle is obtuse. I cannot apply the closine. Okay, so but these are cysts, still are a cyst. So being a cyst and in hypodermis most likely are of dermal origins. Another features, okay, is track to skin sign or what is called submarine sign. What is a submarine sign? It is a part of the lesion of the hypodermis lesion or dermal or hypodermal lesions, okay, part of which or tract, thin tract, okay, extending into the skin or into the epidermis. This is the tract. Can you see it? Here it has different appearance. This is a tract. This is the tract, okay? This one and this one, okay? So this tract, they call it tract to skin sign or submarine sign. It is mostly represent either epidermal inclusion or sebaceous cyst. Okay, the closine. What is the, you know the closine? In the abdomen, the closine, it means what? Renal lesions, to differentiate between Wilms tumor or neuroblastoma. How you could understand that, or you could recognize the lesion that arising within the organ, okay, or arises adjacent to the organ and distorted and invaginating into the organ. If it is arises from the organ, like here, this, when it arises from the skin, okay, part of the skin coming and surrounding the lesion with an acute angle. This acute angle is the closine, okay? This is the closine. When the lesion is not arises from the skin, it is from the subcutaneous, okay? The angle, it will be an obtuse angle, as in these 2 examples, though these 2 examples are pathologically proven to be a dermal cyst, but arises in a hypodermis. Here, it is completely within hypodermis in this example, but here from hypodermis and invaginating into the dermis, but still with an obtuse angle because the epicenter of the lesion within. But if you look here for the superficial fascia, the lesion of dermal origin pushing the fascia posteriorly, even if it arises in the hypodermis. This is my observation, not from the literature. Okay, we have to be cautious. We have to stop. We have mentioned that hypodermal lesion with the skin tract sign, we have to, or most likely to be sebaceous or epidermal inclusion cyst. But unfortunately, okay, these lesions here reported at the base ultrasound study as a sebaceous cyst, misdiagnosed as a sebaceous cyst. But if we could look here, it is a lopulate, it is more heterogeneous. The track is not very clear and not very typical, though sebaceous cyst can be indistinct, can be lopulated, can be heterogeneous, can be, but if it is not very typical, we have to be cautious. At least the patient coming after 6 months, when she presented after 6 months, the lesions getting larger and more vascular. They suggest that inflamed or infected sebaceous cyst, and give the patient antibiotics, and after antibiotic, look for the lesions, even more ugly and slightly increase in size. And at this moment, then they reported as suspicious and proven to be invasive ductal carcinoma. Invasive ductal carcinoma. So this is most likely invasive ductal carcinoma arises from anterior or ectopic TDLUs. Okay? Okay. Here we have 4 examples. Can you tell me which one? All are hypodermal, all surrounded with fat. But what do you suggest? Which one is dermal or related to the subcutaneous? And which one you suggest might be arises from anterior TDLUs? And why? Do you have any suggestion? Okay, I'll tell you. These, except for this one, these are my patients. Okay, I was wondering, when I have seen this lesion abutting the skin and even elevating the skin, surrounded by fat, is it the dermal? Is it dermal in origin? Is it arises from TDLU just in a hypo? So I try to find something to differentiate between these types of lesions. Okay, and I suggest that those lesions arises from the anterior TDLU, supposed to be posterior to the superficial layer of the superficial fascia, because the Cooper ligament attached to this fascia, not attached to the skin. And I report this as a glandular lesion and proven to be fibroadenomas. This and this and this. And if you can see here, you see, look for this lesion, the superficial fascia coming anterior to these lesions. Again, for that one, superficial fascia. And here, though it is interrupted, but at least not pushed. You see, it's going toward the anterior surface of the lesion. That means it is not pushed posteriorly by the lesion. While this is proven to be, this from the literature, proven to be a dermal cyst, having a close sign and having a track sign, but look for the superficial fascia coming posterior to that lesions. Okay. As I told you, why I suggest that, because if it is ectopic within the superficial, within the Cooper ligament is supposed to be ended at the superficial fascia, unless it is cancer and infiltrating going that way. But if it is a benign lesion, supposed to be posterior to the superficial layer of the superficial fascia. And this is a suggestion, and I don't know, I did not prove it yet. I'm trying, just I used to work like that, and all of the lesions, I could follow it, proven to be that one, most of them were fibroadenomas, and proven to be a fibroadenomas, and 1 or 2 were epidermal cyst or sebaceous cyst and treated as epidermal cyst, and I found those lesions anterior to the superficial layer of superficial fascia, while fibroadenomas are posterior to each. You see, as you have seen here, it is just, it's supposed to be ended here. Again, more examples. If you look here, this is these lesions is epidermal inclusion cyst proven. You see, can you see pushing behind, pushing the superficial fascia, and this is hemangioma within the pre-mammary zones also, and you see affecting the adjacent skin here, pushing the superficial layer posterior, though hemangioma can even arise within the mammary zone, but this arises in the pre-mammary zone, pushing the superficial fascia posteriorly. Again, this one is the epidermal inclusion cyst pushing the posterior, the fascia posterior, while this was fibroadenoma pushing the fascia anteriorly. Again, this is from literature, proven to be epidermal cyst. Look for the superficial fascia coming posterior to that lesions. Okay? If we look for these examples, this is angiolipoma, and lipoma arises in the subcutaneous. Again, though it is not complete, but can you see pushing posteriorly? Again, here it pushed posteriorly, while this mucinous carcinoma. Look, this is from the literature. A mucinous carcinoma, I could trace the superficial fascia coming anterior to each. And again, this is cluster microcyst. Look for the superficial fascia anterior, but this is still within the parenchyma, but the parenchyma is, you see, filling the whole space. Some of the parenchyma coming anterior to this fibroadenoma. Again, just you can compare or you can look for the attachment of the superficial fascia. Okay, going to the mammary zone. This is a fatty breast. That is only the mammary zone between brackets. This is almost the mammary zone filling the whole space. This very thin layer of pre-mammary and thin, and this is the pectoralis, okay? But there is no retro-mammary fatty layer. Again, here no retro-mammary fatty layer, the mammary zone, okay? This is the mammary zone, okay? Here the mammary zone is not, the contour of mammary zone is wavy. This is a mammary zone. This is a mammary zone. You see here, the layer, the pre-mammary zone is thick here and thick here, while here it's thin, okay? And the retro-mammary fat, this is very thin layer of retro-mammary fat, and this is the pectoralis muscles. While this one, these are examples of a fatty layer. We can see, okay? All this is the pre-mammary, and this is only the mammary. You see, this is the mammary, and all this is retro-mammary. Okay, for this one here, I can see the pre-mammary zone and part of the mammary zone. I could not appreciate the retro-mammary zone. I could see only the pectoralis muscles. Again, here, this is the pectoralis muscle. Here, this is the pre-mammary zone. This is part of mammary zone, okay? So the mammary zone extends here. This, the fat posterior to which here, this is retro-mammary, and this is the pre-mammary zone. And this is here very clear, okay? So the mammary zone, you know that it is the functional zone, as we mentioned before, containing the ducts and the glands, and it is variable in thickness, variable in echogenicity, and as you know, depend on the age and on the hormone, and we have the hormonal status, pubertal, pregnancy, lactation, postmenopausal, or are affecting these, and even there is inherited parenchymal pattern also varies from area to the another family, and the distribution even of the gland within the breast, as we have seen, it also varies. Okay, here you can see variations in the mammary zones, and these are fatty, and even the glandular. Look for the glandular. You see the echogenicity difference between these examples. And as we have mentioned before, the contour of the mammary zone can be wavy and even can give a palpable abnormality, as we have seen in this case. Okay, this area here outlined with this white, you know, and here they put even a marker at the site of palpable abnormality. You see? And this represent a pseudo lesion. It is only glandular, but we have to be cautious because sometimes, you see, if it's associated with any clinical abnormality or any subtle distortion or abnormal vascularity or whatever, we have to be cautious. This is the previous example, and this is another example. There is here, yes, there is no mass, but there is altered echogenicity and subtle distortion. So that is suspicious. When correlated with mammography, there is a developing asymmetry. So it was a cancer. So we have to be cautious. This is another example here. There is subtle distortion in the area of fibroglandular elevated contour in a case of angiosarcoma. Okay. Let us go for, no, still we are talking about the mammary zone. As we have mentioned before, you see, almost all ducts and lobule within the mammary zone. That means we expect virtually all pathology to be visualized within, okay, within the mammary zones. And most of the subcutaneous or pre-mammary and retro-mammary involvement is secondary to extension from the mammary zone. But there are few percentage of exceptions that there is ectopic TDLUs in pre-mammary zones and rarely in retromammary zones that can result in glandular lesions in these locations. If we look here, we have just within the mammary zones multiple lesions, benign and malignant. But here, this lesions is posteriorly located and extended into the retromammary zone. This is posterior, but still contained within the mammary zone. But this one here extended into the retromammary zone. Okay, let us go for the retromammary zone. Okay. Definitely now you are oriented where exactly the retromammary zone. When we talk about the pre-mammary zone, we have mentioned the 3 zones. When we discuss the mammary zone, also we have mentioned the 3 zones, and now we can recognize where exactly the retromammary zone. The retromammary zone, it is the fatty layer posterior to mammary zones. If you see here, this is the retromammary zone. You see, getting thin, thin, thin here. And here, as we have mentioned before, the mammary zones can be wavy, anteriorly or even posteriorly. And here you can see, this is the pre-mammary and this is the retro-mammary. A fat lobule posterior to mammary zone representing retromammary. This is the pectoralis muscle, and all this thickness of fatty layer here representing the retromammary zone. Okay, what is the retromammary zone? As we have mentioned before, retromammary zone is a fatty layer. It is part of the skin, as the pre-mammary zone. It is posterior to the mammary zone, i.e. posterior to the posterior or retromammary fascia. This hyperechoic layer, the retromammary fascia, the fatty layer posterior to which is the retromammary zone, okay? Lies between the posterior or retromammary fascia and the pectoralis muscles. It is thin. It is contained of fat lobule and loose connective tissue. Okay, that is the one. And that is the one. Contain few Cooper ligaments. Okay, this is the Cooper ligaments. This yellow line represents the Cooper ligaments. Okay, here we can see this is posterior or retromammary fascia, and this is the pectoralis. So the fatty layer here is the retromammary zone. It is a potential space or a potential persa, okay? And it's also known as Chasian's fossa or Chasian's persa, okay? And they use it, the plastic surgeon, in reconstructive breast surgery, okay? It is usually appear as a thinner, as we have seen in the previous example and even here in this example. It is usually thin compared to the pre-mammary fat. Why? And if the same patient, we have seen mammography and ultrasound, it will appear wider in the mammography, but it will be narrow on ultrasound. Why? Because on mammography, we pull the breast away from the chest wall. So we open that area. While on ultrasound, the patient lying flat, okay? Lying on her back. So the breast going toward the chest wall. And when you compress with ultrasound transducer, you compress it against the chest wall. So you will make it by ultrasound, you will make it thinner, or you make it relatively narrow layer. So that is why it is apparently narrower on ultrasound than on mammography. Okay, if you look here, we couldn't appreciate where is the retromammary fat. Why we could not see it? It is obviously dark, it is black, the area. So this is a technical issue. So we have to consider while scanning to adjust, okay, our setting and focusing to visualize until the retromammary, the pectoralis, the ribs, and even the pleura, okay? We have to, you can compare this example with these examples. Here, definitely, it is clearly visualized down to the pleural surface. Okay, this is my patient. Can you see any lesion here in this case? Okay, that is the lesion.
It
With
looks
difficult,
like
huh?
looks like the primary fat.
Yes, it is iso. It is retromammary and it was iso. And it was not palpable. It was not palpable, you see. Look, but here with some manipulation, adjustment in the machines and do go and forth. And so at the end, we could just demonstrate the lesion a little bit more clear. Okay, and that was invasive ductal carcinoma, proven to be invasive ductal carcinoma in a retromammary fat. But if you look, part of the lesion within the mammary region and extending into the retromammary fat. But As you know, this is one of the forbidden area of the breast cancer. So we have to be cautious while scanning, adjust our machines very well. We have to look carefully for the retro-mammary area throughout the breast. Okay? As we mentioned, breast cancer mostly arises from the mammary zone and extending into the retro-mammary zone as secondary. Rarely or extremely rare can be ectopic as in the pre-mammary zone. And even look for this is adenosis, just extending from the mammary zone posteriorly. And these examples of cancer, even this one simulate a fibroadenoma. If you look for the ferris without looking for the margin carefully, you might say this is a fibroadenoma, which was proven to be cancer from the mammary zone extending into the retro-mammary zone. Okay? As we have mentioned before, posterior TDLU like anterior TDLU can be ectopic, but this more extremely rarer than the anterior one. Here, this is even the posterior Cooper ligaments are shorter and smaller, not like the anterior one. Okay. So posterior to retromammary zone is the muscles. And the famous one is the pectoralis major. As you know, the two-thirds of the breast resting posteriorly into or bounded posteriorly by the pectoralis major. And the pectoralis minor is posterior to the pectoralis major, posterolateral, okay? And seem to be like a triangular structures. And both structures appear as stripes or striated alternating hyper and hypoechoic linear bands of echo run parallel to the chest wall. But it is variable. Look for this. This is the pectoralis major minor, and look for the pectoralis in this in this case. Okay, there are variations in appearance and in thickness. Serratus anterior lies laterally to each breast. Okay, and latissimus dorsi, you might see it if you go toward mid-axillary line. When you go inferiorly, scanning the breast, you might see the external oblique muscles or upper extent of the rectus sheath. Okay. Variable appearance of pectoralis muscle. Look for the pectoralis muscles. Look for here. You see, look for here and see it here in this example. This example here, here, here. In older people, okay, adipose degeneration or fatty degeneration, the muscle bulk will reduce and it will become more echogenic, not like you see in those physically fit or athlete people. Usually it is bulky, and those alternate hyper and hypo stripes will be more visualized, more obvious. But with elderly, it will reduce in size and increase in echogenicity due to fat degenerations. This also example of mine, okay? Here we can see, in this case, very obviously, these lesions, so circumscribed from here, but posteriorly breaking, and look how it is infiltrating the pectoralis major and pectoralis even minor muscles. And it was surgery and pathologically proven all these, okay, findings. And this is another example here also, my patient extending and infiltrating the underlying pectoralis, and as well as in this case. So the cancer can penetrate into retromammary fat down to the pectoralis muscles, and sometimes even more deeper to the pectoralis and these into the chest wall. Okay. So posterior to the pectoralis are ribs and costal cartilages. Here, this is the pectoralis muscles, and you can see this curvilinear, okay, hyperechoic with posterior shadowing and ribs. And this one is a costal cartilage, but it is posterior to the pectoralis in cross section, hypoechoic costal cartilage. So if we have seen oval hypoechoic lesion-like structures, we have to make sure, is it a costal cartilage or is it a lesion? We discussed it before, but again, we are going to discuss it here because it is relevant. It is coming posterior. We are going from superficial to the deep structures. So posterior to the pectoralis, if we have seen it posterior to the pectoralis, most probably it is a costal cartilage, but this is not enough. It can be a lesion arising from the chest wall. We have to change the plane of transducer. We have to rotate the transducer in an orthogonal plane to confirm that it is elongated and extended and connected with the rib, and it is not a mass. Here, this it's seen posterior to the pectoralis, most likely costal cartilage. We have to go further to make sure. When we scan here, we can see where we can see intercostal muscles, the pectoralis and the intercostal. We can see here the pleura. Okay, we can see another similar structures. So now we are sure that this is costal cartilage. This one definitely, it is not a costal cartilage. That is breast lesion. Why it is breast lesion? Because I relate the lesions to pectoralis, and it is anterior to the pectoralis. Since it is anterior to the pectoralis, that means it is within the breast. It is related to the breast. It is not a chest wall. This here, these are costal cartilage. At least I have seen two of which, and I could appreciate the intercostal muscles and the pectoralis anterior to each, but I can see something anterior to the pectoralis, so that when anterior to the pectoralis is the breast mass, while those posterior to the pectoralis are not related to the breast. But since I could see more than one separate, I have seen it elongated in orthogonal view. I could see the intercostal muscle in between, the pleura posterior to it sharply demarcated. So these are costal cartilages. And here we can see this video, you see. Here, this is the pectoralis muscles, and you can see the costal cartilage, and in orthogonal view, so it is elongated. So very important to visualize it in an orthogonal view as elongated structures connected to the ribs, and we could appreciate even, you see, posterior to which we can see intercostal muscles, and we could appreciate the hyperechoic line of the pleura and dirty shadowing of the lung posterior to which. Okay. As we have non-glandular lesions in the pre-mammary zone, we expect to have non-glandular lesions in the retro-mammary zone. The pre-mammary zone, mammary zone, retro-mammary zone, and resting into the chest wall. So from the chest wall, we expect to have a lesions. And as we have mentioned before, the claw sign. If the lesion arises from the breast, it will demonstrate the claw sign. If it arises from the chest wall, it will demonstrate an obtuse angle, like the mediastinal lesion, the pleural lesions, skin lesion, hypodermal lesion. If the lesion arises from the dermis, it will demonstrate the close sign. If it arises from the hypodermis, it will have obtuse angle. And the mediastinal lesion will give obtuse angle. If it is within the lung, it will give the close sign, and so forth. If renal lesions, within the renal, it will give a close sign. If it is suprarenally and infiltrating or giving a mass effect into the renal, it will be extrinsic mass and it will give obtuse angle. And the same here in the breast. If it is from the chest wall, the angle will be an obtuse angle. Okay, these here we have different examples. These lesions, this lady presenting with a painful swelling in her breast. On ultrasound, demonstrate the protruding costochondral junction. You see, it was the costochondral junction presenting as a palpable, painful breast swelling. Again, another example here, this is the deformed rib protruding anteriorly, presenting as a breast swelling. Okay, so these are two examples of non-glandular breast lesions from the chest wall. Here, this lady presented with breast pain. The breast pain due to underlying rib fracture. Can you see the disruptions in the cortex of the ribs and minimal few millimeter displacement? But in this example, there is disruptions and irregularity and fragmentation in a pathological fracture due to breast cancer metastasis. These can be seen, can be detected while scanning your breast or while scanning the patient's breast. And here we have examples of breast rib metastasis, okay, presenting as a hypoechoic vascular lesions. You see, while scanning the breast, underlying ribs demonstrate this hypoechoic vascular lesions due to breast cancer metastasis. This is a similar lesion, but with different pathology in a case of a myeloma rib lesions. If we look for this, we can see here the ribs looks irregular. It looks irregular, hyperechoic, but it is really irregular due to involvement by metastatic disease. This lesion within the pectoralis, in a case of pectoralis muscle sarcoma, and these chest wall lesions in a case of schwannoma. Okay, while this example here, these are ribs. I can see here two ribs, and this intercostal space between third and fourth intercostal space. And here I can see the internal thoracic vessels, and I could appreciate an oval lesion here, pathologically proven to be metastatic intra-mammary lymph node. Okay, we can even see deep to the ribs and intercostal, as we have mentioned before. We can visualize the pleura and underlying lung. Here, along the pleural line, there is a hypoechoic irregular lesion, and another one here in a case of, sorry, in pleural metastasis, excuse me. In a case of pleural mets, okay? In the other example here, we can see irregular pleural thickening proven in this CT chest. And the patient, she had mastectomy. Most probably pleural fibrosis from previous radiation or something like that. Okay? Excuse me, Sumaya, excuse me. May close your mic, please. There is background noise. Okay. Let me ask you, what this line, hyperechoic line, represent, and what does this hyperechoic line represent? Huh?
Pre and post pre and post
Excellent, Sumaya. Yes, you're right.
facial.
Which fascia? Yes, you're right. This is pre-fascia. Pre what?
Second zone.
What? طيب.
Second zone.
Let me ask you, what is this structure in between? Which zone? This zone.
This mammary zone.
The mammary zone. So this it will be
Pre
شنو?
and post mammary facial.
Yes, this is excellent. This is the pre-mammary fascia, and this is post-mammary fascia, and this is glandular fascia. And what about this? This what? This what?
This is retro.
Yeah.
Yeah, this is I don't know. This is subcutaneous.
Subcutaneous. Yes, this is the skin,
Yes.
and this is the subcutaneous or
Subcutaneous.
pre-mammary zone or subcutaneous fat.
Subcutaneous.
Subcutaneous fat. Yes, yes, yes. And here I cannot tell. It seemed to be the pectoralis. You see, I'm not sure if this is retromammary zone and this pectoralis, or all this is the pectoralis, but at least you are correct. These are anterior mammary fascia and posterior mammary fascia, or pre-mammary fascia and retromammary fascia. Okay. There is a story in these slides. I have shown you this illustration before. Do you remember that? So here, do you remember this illustration?
Yes.
Do you know story behind this illustration? Do you remember?
No, I forget the story, but I
Okay.
remember.
Okay. This illustration, okay, that is the breast. This is the whole the breast. Okay. And this is the pre-mammary zone, retromammary zone, and this is the mammary zone. This is all the mammary zone. Looking for the mammary zone, this is 1 centimeter from the contour of the fat glandular interface, okay? Posteriorly, laterally, and anteriorly, like that. This one is 1 centimeter. So at the periphery of the mammary zone, they found 75% of cancer arises in this or within this centimeter wide zone of the mammary zone in a pre-mammary, in the menopausal, okay, or reproductive or young woman, less than 50. And when we discuss, okay, the terminal duct lobular unit, they have mentioned that most of the terminal duct lobular unit are at the periphery, at the periphery of the mammary zone. Even in early in this lecture, we discussed that. We have mentioned that most of the terminal duct lobular unit are anterior and at the periphery of the mammary zone. Okay? And as you know, 75% of breast cancer arises from terminal duct lobular unit. Do you remember the AABs and DABs? We have mentioned previously. the acinar adenocarcinoma of the breast and the ductal adenocarcinoma of the breast. Do you remember that? Okay, we mentioned in the previous lecture the new classification of breast cancer is AABs or DABs, okay? And there is a third one. Let us concentrate for those two. The AABs is the acinar adenocarcinoma of the breast. The breast arises from the acini of the lobule. And they found that this represents 75%. Okay, 75% arises from the acini of the TDLUs. And they said that it is usually presenting as grade 1 and 2, and it has a good prognosis. While the DABs, ductal, it has a poorer prognosis because it is usually presenting late and presenting with calcification, and calcification usually presenting late. I try to join these together, this information in these slides. Being in premenopausal, because in postmenopausal, the breast involuted and the number of TDLUs, it will regress, significantly regressed, as you know. But in premenopausal, the majority of TDLUs are at the periphery of the mammary zone. So at this zone, they have mentioned that where the breast cancer incidence is the highest. But previously, when I found that status, okay, or that sentence, I didn't find the explanation why they found it is common within this zone. They did not mention why. Okay, but when I found this, when I found the 75% of breast cancer arises from TDLUs, and the majority of TDLUs are at the periphery of the mammary zone. So I joined the information together. That the explanation for the premenopausal woman, that most of the cancer arises here. Unluckily, at these locations, if the cancer arises here, it will be close to the fat glandular interface, adjacent to the fat. So it will make reaction, like in this my patient. Look for the cancer here, causing distortion into the adjacent fat and even affecting the skin. So immediately it will present it by the change into the adjacent fat. So it will present early. That is why having a better prognosis or a good prognosis, okay? While the ductal carcinoma arises from the duct, and the duct, either the major duct there in the retroareolar, or here usually seen within, okay, within the fibroglandular or within the mammary zone, and surrounded with this a lot of fibroglandular tissue and a lot of stroma. Okay, and when it presents with a calcification, the calcification is late and not close to fat to give early reaction. So it will present, or it will detect it late, and that is why it has a poorer prognosis. And as that previously they have mentioned that DAPs or ductal adenocarcinoma presenting more with cyclope syndrome. What is cyclope syndrome? It involves the whole lobe before the cancer being detected. So with a poorer prognosis, and even sometimes with metastatic adenopathy. Is it clear? Is that clear? Is it logical explanation? It is my explanation. Is it logic? I don't know. I tried to join all information together and to make use of it. I suggest that probably, and even now the illustration, these pink lines are mine to make it a little bit beautiful, not just a blue. That is for you, to make you happy. Huh? Let us go for the next slide. Okay. This is examples, 3 examples from literature, and this is mine. These are the CIS. We have seen here, you see, anterior, anterior, anterior. And we have mentioned before, look here, this all mammary zone. Look, if we divide it into 2 halves, transversely like this, look for the anterior and for the posterior, where the TDLUs are large and numerous. Into the anterior half, yes. Anteriorly, the TDLUs are large, and as we have mentioned before, you see, if this segmental duct, the posterior are less in number and smaller, and the terminal extralobular terminal duct lobular unit are shorter compared to the anterior one. And if you look for this example from the literature, also look for the lesions. Most of the lesions are anteriorly. Okay? So that is why, because the TDLUs are more numerous anterior and more numerous at the periphery of the mammary zone. And as we have mentioned before, we said are also more at the base of Cooper ligament. Do you remember? I'm revising the lectures only in these slices. I'm trying to make a summary for you. You see? Here, can you see this? Can you see the angular margin? Can you see this is a Cooper ligament here? Because we have mentioned that at the base of the Cooper ligament or Cooper peaks, the TDLUs are also larger and numerous, and that is why, even look here, you see this cancer at the Cooper base and extend into, and we mentioned the anterior mammary fascia make resistance for the spread of the cancer. But because this is open here like a gate, the resistance here is weak. That is why the cancer at the beginning extends through the Cooper ligament and giving this angular margins. And do you remember why the lesions completely surrounding with fat? If the breast is fatty, because we said while involutions, the TDLUs and ducts entrapped and left within the Cooper ligaments from where these lesions arise. Okay? And the pre-mammary lesions, the pre-mammary zone lesions or subcutaneous lesions arise from ectopic TDLU, we said.
Yes. Ectopic TDL. Yes.
From ectopic TDLUs. Okay? This is a papilloma, if you remember, and this is cancer. Arise from an ectopic TDLU within Cooper ligaments. Okay. And regarding the dermal and hypodermal lesions, we said that if the lesion is completely contained within the dermis, that means it is a dermal lesion. And if half of the lesions contained within the skin with a smooth margin and posterior wall enhancement, look for the posterior wall smooth, we enhance, posterior enhancement, these are reassuring findings. And most of the lesions, you see, look here, this is the inferior, the inner dermal lines. Most of the lesions contained within the skin, and if you put the angles, you might see even the claw signs. All these are reassuring signs. And the smooth, now we can say smooth tract, epidermis tract. Okay, the lesion itself is smooth, okay, and there is a smooth epidermal tracts, or these features are reassuring of just dermal cyst, either epidermal inclusion cyst or sebaceous cyst. And the posterior pushing line or posterior pushing of the superficial layer of superficial fascia, and this is additional signs. You see, this is proven to be a dermal lesions. Can you see the fascia coming posterior? And if we can follow this, can you see it here? Look for the fascia. This is, look here, part of the fascia. You see, you can see the lesion pushing the fascia, okay, posteriorly. And if the lesions, you see, if it is, sorry, the lesion can be hyper, or isocoic, okay? And it can be over-rounded or irregular, can be circumscribed, indistinct, or loculated, can be without vascularity, with central or peripheral vascularity, can be with presence or absence of perilesion, fatty changes, and edema. It depends on which type of the lesions, and if it is if the lesion inflamed or not. So sometimes it is typically benign lesions with typical benign appearance, but sometimes it might be of suspicious appearance, but still it can be a sebaceous or epidermal inclusion cyst. But if it is suspicious, we should raise the possibility of biopsy. So this characteristic of dermal cyst necessitate an accurate differential diagnosis. However, differentiating epidermal cyst from other subcutaneous cyst or solid tumor or vascular lesion is sometimes challenging, and many differential lesions can be misdiagnosed as epidermal cyst on initial ultrasound, and partly because the incidence of epidermal cyst has been reported to be second highest after lymphoma. We have seen this example. It is hypodermal with the tract extending into the dermis and proven to be an invasive cancer. At the baseline ultrasound was diagnosed as a sebaceous cyst. But look for it doesn't push, you see, doesn't push the superficial fascia posterior. It is interrupted, it is cut. Can you see it here? This is the fascia. It is interrupted. So sometimes we can use these signs to help us as additional feature to differentiate between sometimes subtypes, some of the lesions. This is sorry, this is sebaceous cyst. Okay, proven, pathologically proven sebaceous cyst. Can you see here the superficial fascia pushed posteriorly? And this is also a sebaceous cyst. Can you see the posterior fascia, how it is pushed posteriorly? Okay, as with other breast lesions, suspicious imaging feature should be sought in addition to determining the anatomic origins. That means if we have seen a lesions, okay, involving most of which within the dermis, but it is irregular, it is heterogeneous, it is indistinct, or it is microlobulated, we should not say, since by location that's supposed to be sebaceous cyst and that is it. No, we have to consider, okay, the other features and to characterize it accordingly, and to characterize and to categorize according to these characters, according to the BIRAD lexicons, and we might recommend biopsy according to these features. Okay, so the last slide. This is,
Skin,
that is a gift, huh? Skin, huh?
subcutaneous layer, subcutaneous fatty layer,
Okay, huh?
mammary zone or fibroglandular tissue,
Mammary zone, huh?
retromammary fat,
Retro-mammary fat, huh?
pectoralis major.
Excellent. Pectoralis major. Excellent. Okay. So to summarize, understanding the detailed breast sonographic anatomy and ultrasound appearances is essential to avoid misinterpretations. And as you know, and as we discussed, there are 3 zones from superficial to deep: pre-mammary zones or the subcutaneous zone, the mammary zones where almost all TDLUs and lobules embedded into the fibrofatty stroma, and where is the action, where is almost all pathology present in this zone. And then the deepest zone is the retromammary zone, which contain fat vessels and lymphatics. The differential diagnosis varies for each anatomic zone according to the contained structures, as we have mentioned. And breast lesions are not always confined to the parenchyma. Many superficial lesions can be misdiagnosed as epidermal cysts, as we mentioned before on initial ultrasound examination. Why? Because of high incidence, and as we mentioned, it is the second highest after lipoma. Ultrasound typically has a higher resolutions or for localizing the dermal and hypodermal masses, and it is superior to mammography and MRI in detecting these lesions. And hypodermal lesions, although usually are benign, may include lesion arise from the anterior TDLUs, including breast cancer. Accurate anatomic localization and categorization of superficial mass by lexicon terminology is important to differentiate probably superficial cancers from benign lesions, and to avoid misclassifying small superficial breast cancer as a benign dermal lesions and properly diagnose superficial small breast cancer breast imagers or radiologists must be aware of possibility of occasional superficial or ectopic TD LUs, undetermined or non-specific axillary lymph node when associated with superficial cancer with such a location predictive of metastasis. It is highly recommended to biopsy these nodes for pathological diagnosis. And thank you very much for being patient and for attention. And sorry for taking you so long. And I hope it was beneficial for you. Do you have any question? Huh? Any question?
Thank you much, yeah, boss.
Huh?
It was a very nice lecture. We did enjoy and benefit a lot from it. Some things we came to know for the first time. It was a very well structured and nice lecture. Thank you so much.
No, thanks for my duty and thank you for your appreciation. Any of the audience have any question? Everything is clear or was clear?
Alhamdulillah, yes. Thank you so much.
Okay, so we can, huh? Someone is asking? Islam?
أيوة يا boss.
Huh?
Thank
I heard,
you boss.
I heard your voice. I thought that you are asking me.
لا, I am mute to thank you boss. Not to ask
Okay.
you. Thank you.
Okay.
Thank you very much.
Okay, thank you for your appreciation.
Thank you.
Okay, if you have no questions, we can end the recording.